Hello, I'm Dr. Matt Ewen. I'm the Chairman of Neurosurgery at the University of North Carolina and the Director of the Brain Tumor Program at the UNC Lineberger Comprehensive Cancer Center. Today I'd like to talk with you about brain cancer or brain tumors. Particularly, we'd like to focus on tumors that start in the brain, often called primary brain tumors or gliomas. Today we're going to talk about brain cancer or brain tumors. There's several different types of brain tumors, and it's important from the beginning to understand whether the tumor we're discussing started in the brain. We call that a primary brain tumor, and the most common form of that is a glioma. Or if the tumor spread to the brain from somewhere else, and we call that a metastatic brain tumor. Those often spread from other types of cancer like lung cancer, breast cancer, or melanoma. However, any sort of tumor can spread to the brain. This video is going to focus on tumors that started in the brain rather than those that spread from somewhere else. We'll have a separate presentation available to talk about the metastatic brain tumors. Now, there are about 75,000 primary brain tumors a year in the United States. That's approximately 25 tumors for every 100,000 people. About 1/3 of those tumors are malignant or cancerous tumors. Unfortunately, about 2/3 of the tumors are benign tumors. Again, today I want to focus my comments on the cancerous or malignant brain tumors. As a doctor who treats patients with malignant brain tumors, I'm interested when I meet a new patient to learn many things about them and then about their tumor. The most important things for me to know about their tumor are the grade of the tumor and the type of the tumor. So let me explain that in a little more detail. We traditionally grade the tumors on a scale of 1 to 4. And the grade 1 tumors are the lowest, and the grade 4 are the most aggressive. In general, the grade of the tumor tends to track with the age of the patient. So younger patients in their teens or 20s are more likely to have a grade 1 tumor. The grade 2 tumors tend to occur in the 20s and 30s, and the grade 3 and 4 tumors tend to happen in people who are older. Grade is certainly a very important thing to know about a patient and their tumor when we're deciding on treatment and trying to give the patient information about the tumor. The other important thing to know is the type of tumor. There are two main types of tumors that occur in the brain. The first are astrocytic tumors. That's one type of tumor cell in the brain, the astrocytes. And the other are oligodendroglial tumors. That's a couple of big words that even I struggle with. And so we frequently call these the A's and the O's, the astrocytes and the oligodendrocytes. And those two types of cells are just cells that support the tissue in the brain. The most important cells of the brain are the neurons. That's what makes us think and run and be ourselves. But those neurons need help from other cells, and those cells are called the glia. And the astrocytes and the oligodendrocytes are just members of that glial family. So for every patient I meet, once I get to know them and learn about their story, I want to know about their tumor, what's the number grade, and then what is the letter, the A or the O that goes with this. In general, the lower the number and the more O in the tumor, the better we are. So a grade 2 O tumor at the outset would be easier to treat than a grade 4 A tumor. Now, the naming of brain tumors can get very confusing very quickly, but there are probably a couple other terms that would be useful for you to know as you learn about brain tumors. Grade 4 tumors are often called glioblastomas, or abbreviated GBM. And so the grade 4 tumor, or the GBM, is the most aggressive tumor. And the low-grade tumor, the grade 2 tumor, would be the least aggressive tumor from the spectrum of grade 2, 3, 4 tumors. We've talked about a number of different kinds of brain tumors. These primary brain tumors that can be grade 2 tumors, grade 3, grade 4, and can start from either the astrocytes, which are the A's, or the oligodendrocytes, which are the O's. All of these tumors, regardless of the grade or the type of cell, have treatment options and modalities that can be used to stop their growth. Some can be removed, others are treated with chemotherapy, some are treated with radiation, and many receive a combination of this. Regardless of what type of tumor you or your family member or friend has, there's likely to be very good treatment options available to them, and we'll get into that in just a minute. So very often when I meet a patient for the first time who's been diagnosed with a brain tumor, they'll ask me what caused the brain tumor, and whether there's risk that others around them could develop brain tumors as well. For some types of cancers, like breast cancer, we know that a strong family history predicts your risk of developing that. If your mother and your aunt and your sister had breast cancer and you're a woman, your risk will be higher. For brain tumors, there really isn't this strong family pattern. There are a few very rare syndromes where multiple members of the same family will have brain tumors, but usually families already know that this runs through their genes. Most brain tumors arise to patients without a strong family history. The second question I'll get asked is whether there are any known causes for this. We all know that lung cancer can be caused by smoking. There's no such relationship between brain tumors and behaviors. There's no close correlation between living under power lines. Many patients ask whether using cell phones are a risk factor for developing brain tumors. This has been studied extensively. There's really very little data that brain tumors develop because of exposure to these types of everyday things. If they were caused by cell phones, I think most neurosurgeons would have brain tumors as well, since we're such heavy users. In short, there's really nothing that you or your family member did that set them up to get this tumor. We'll have to focus our effort going forward on what we can do to treat the tumor. Next, I'd like to talk a little bit about the symptoms patients have when they develop brain tumors. Since the tumors arise in the brain, they can present to patients or become known through a variety of different ways. As the tumors grow, they can produce headaches because they push on normal brain and on the covering of the brain, which has many nerves, and patients will develop headaches. That's a very common way for brain tumors to present. Alternatively, the tumor may push on important areas of the brain. Many of us see people having neurologic problems in the setting of a stroke, and we recognize that the patient becomes weak on one side or has difficulty speaking, as I just did, or develops problems with walking or balance. Brain tumors often produce these same symptoms. One key differentiating factor is that a stroke is usually a very sudden occurrence. Brain tumors tend to come on more gradually because the tumor is slowly growing, and as it grows, it pushes a little bit more and a little bit more on the important areas of the brain. So it's very common for people to have subtle neurologic problems that become more pronounced, and finally either they or their loved ones say, something just isn't right, we should get this checked out. In the last decade in medicine, there's been a significant increase in the number of CAT scans and MRI scans that are done of the brain to work up things like headaches, falls from bicycles, double vision. And so more and more we're finding brain tumors that probably haven't caused any symptoms. As physicians, we call that an incidental finding. I fell off my bike, I bumped my head, I got a CAT scan, and lo and behold, there was the start of a growth of a tumor. In a sense, that's a good thing because we find the tumors while they're smaller, maybe at a lower grade, and while the patient is in better shape neurologically. And all of those things allow us to be more effective in treating the tumor. Many patients present to me as a neurosurgeon with an MRI scan or a CAT scan that shows a mass in the brain, and they've been told that this is likely to be a tumor. At this point, it's not known for sure whether the finding on the MRI is a tumor. With experience, we can look at these scans, and as physicians, we start to make a list of the most likely diagnoses. And tumor may be the most likely thing, but a stroke, a blood clot, multiple sclerosis, infection, all of these things are on the list. The most important thing for getting a diagnosis of a brain tumor is to get some form of a biopsy or a tissue diagnosis. And by this we mean that a small or a large amount of the tumor is submitted to a pathologist who examines the tissue under a microscope, may look at the genetic makeup of the tumor, and then gives us a diagnosis as to exactly the type and grade of the tumor. Until we have a tissue diagnosis, and while we're basing all of our decisions on an MRI scan or a CAT scan, we're making educated guesses about what the tumor is. So it would be very common for a patient diagnosed with a new lesion in their brain to undergo some sort of a biopsy or surgical procedure to get a definitive diagnosis. When a patient is diagnosed with a mass in the brain and comes to meet a neurosurgeon, there's usually a recommendation to get a tissue diagnosis. This can be done one of two ways. The first is a simple biopsy, which is sometimes called a stereotactic biopsy, and the second is an open surgical resection of the lesion. Depending on the particular case, the age of the patient, their neurologic condition, the size of the lesion, and the location of the lesion, I might recommend to the patient either a biopsy or an open surgery. Let's talk a little bit about each of those and when we might recommend one over the other. The stereotactic biopsy is the simpler of the two procedures that can be done to get tissue to make a diagnosis of a brain tumor. The goal of the biopsy is to guide a probe or a needle down into the abnormality and take several small bites. Those bites are submitted to pathology and a tissue diagnosis can be made. Usually this is done with guidance from either CAT scan or MRI. This is very much like the GPS that many of us use when we're trying to get somewhere in the car. We can take the MRI scan and the surgeon can pick the exact spot on the MRI where they want the biopsy to come from. And then in the operating room, using a guidance computer, guide a probe down to that exact spot and take several biopsies. The biopsy procedure usually involves only a very small incision and one small opening in the skull that the probe passes through. It's not a treatment. We're removing only a very small part of the tumor, so it doesn't relieve the mass of the tumor, and it only takes out a small piece. But it does get us an answer very quickly, and it has only a very small amount of risk associated with it. The biggest risk is at the time of the biopsy, when that little bite of tissue is being made, that there could be bleeding. And that happens very rarely, maybe 1% of the time for each biopsy that's taken. Patients often go home the same day or the next day with just a small incision on the scalp. And then several days later, the answer will come back as to what the lesion is. Is it a tumor? And if it is a tumor, what kind of tumor? The advantages then of the biopsy are that it's a small procedure with a very short stay in the hospital. The disadvantage is that we only biopsy one small area. So if we have a large tumor, we take a bite from one small area, then we know exactly what that area of the tumor is. But there may be another area of the tumor that's a higher grade area, and we might miss that with the biopsy. Obviously, as a surgeon, I want to aim the biopsy at the area that looks to be the most aggressive or the most worrisome. But that, what we call sampling area, is one of the risks of the biopsy. I usually do a stereotactic biopsy in patients who I don't think I will ever be able to do a full removal of, or in somebody whose case is very atypical and I'm not sure if it is a tumor at all. If I see something that's very close to the surface and very easy to remove, rather than putting the patient through a biopsy and then bringing them back several days later and saying, yes, it's a tumor, let's go do an open surgery, I usually recommend going straight to the open surgery. And I'll talk in just a moment about what that is. So I tend to use the stereotactic biopsy for deep lesions that would be hard to remove, or unusual lesions where I'm not sure if it's a tumor or not. For many of the patients I meet who've been given a tentative diagnosis of a brain tumor or a brain cancer, when I meet them and examine their MRI, it's clear to me that they have a large mass in the brain that has a good chance of being a tumor, and that the size of that tumor might be causing them the symptoms that brought them to me, like headaches, or weakness, or speech trouble. For those patients, it may make good sense to combine the biopsy or diagnosis part with a treatment part, and an open surgery, which is sometimes called a craniotomy, to remove the tumor will not only give us some of the tumor to look at to make a firm diagnosis, but also relieve the pressure from the tumor and actually start help treating the tumor by removing as much of it as possible. For those patients that I meet, I usually recommend a craniotomy rather than a simple biopsy because I think it gets us farther ahead. Remember that both the biopsy and the open surgery require going to the operating room and usually require going under anesthesia. Whenever we can get a patient treated and get the best treatment in place with a single trip to the OR instead of 2 trips, that's always better. There are some risks to an open surgery. It's a surgery on the brain, and whatever part of the brain is nearest the tumor is the part that's most at risk. You would want to ask your surgeon, what are the areas of the brain that are near my tumor that might be at risk with surgery? those are probably the same things that are getting pushed on by the tumor. So if you're weak in your right leg because of the tumor you have, then one of the risks of surgery might be to make that leg weaker. Our hope, of course, is to get the strength back in your leg by taking the pressure off it. But with any surgery, there's a small amount of risk. Usually the risk with a craniotomy for a tumor like this is on the order of about 5% chance of a major problem. Now, not all of those problems are permanent, and not all of those are irreversible, but patients should be prepared before they decide to go forward with surgery for the small chance that there could be a complication such as infection or swelling or bleeding from the surgery. A majority of patients who have a craniotomy to remove their tumor will be in the hospital 2 or 3 or 4 days, and when they go home should feel pretty good, but we'll find that they get tired very easily. A majority of them probably feel better from the standpoint of their neurologic problem, but it does take a number of weeks to really get over a major surgery like this. For patients who've undergone a biopsy procedure or an open removal of their tumor, craniotomy, it's very common for them to go home before the final diagnosis is available. I usually see patients back approximately a week after surgery, and at that visit I will make sure that they're doing well. I'll check on their medication. I'll often remove the sutures that were put in it at surgery. And most importantly, I'll be prepared to discuss the results of the pathology report. That means I'll have an answer about what the kind of tumor is. We've already talked a little bit about the grading scale 1 to 4 and the types of tumors, the astrocytic tumors, the oligodendroglial tumors, and there are some other less frequent tumors. But I'll relay this information to the patient and try to put that into context. It's very difficult to predict for a particular patient what will happen with whatever diagnosis. When doctors get numbers about a patient's prognosis, they think of it in terms of big groups of patients. If I have 100 patients with a tumor like this, in how many of those patients will that tumor grow back in the next few years? That's not particularly useful when I'm talking to one particular patient, because that patient is really concerned about how they're going to do. They wish the other patients well, but they don't want to know out of 100 patients what's going to happen. They want to know what's going to happen to me. We'll do our best to tell you about the type of tumor it is and what the different treatment options are, but understand that your doctor can't know for certainty for you exactly what will happen. Now, a very common question I get at this visit is whether we were able to remove the whole tumor or not. And you might think that that's really something that is up to the skill of the surgeon. But in reality, I think the type of tumor is the most important predictor of that. We know from experience that with the higher grade tumors, the grade 3 and grade 4 tumors, that even if we remove all of the tumor that we can see at surgery, and we remove all of the tumor we can see on an MRI scan, and we can compare one from before and after surgery, that there will always be little fingers of that tumor that are still left inside the brain. And the reason for this is in part because the tumor occurred in the brain. When we do surgery on the colon, for example, we can go a foot to the left and a foot to the right, and we can get some of the fingers of the tumor. In the brain, we can't take wide margins around the tumor, so there may always be tumor cells in the normal brain. This is why for a patient who has a grade 4 tumor, the surgeon may say, I took out all the tumor I could see, and I don't see any tumor on the MRI, but I want you to strongly consider going forward with further treatment. And you might say, well, why do I need more treatment if you got all the tumor out? And that's because we can't see the little fingers, the little cells of tumor that might be hiding in the normal brain. But we can treat them with other forms of treatment, just usually not with surgery. So the main goals at the first visit are to educate the patient about the type of tumor it is, give them the details about the surgery that they may not remember from the hospital stay, and then start to talk about a treatment plan going forward. So as we've discussed, the first step in the treatment of a patient with a brain tumor is to get a diagnosis and to frequently remove as much of the tumor as can safely be removed. At this point, you may find that your team of doctors and healthcare professionals broadens, and you may meet a medical oncologist or a neuro-oncologist, which is a doctor who specializes in giving chemotherapy and medicine to treat tumors, You may also meet a radiation oncologist. Now, that's not a radiologist. A radiologist looks at x-rays, like the MRIs that you probably had. The radiation oncologist treats tumors with radiation. And often at this point, the neurosurgeon, someone like me, will take a step back on your team and be a supporting member of the team. And the medical oncologist, partnered with the radiation oncologist, will take the lead in treatment. Some patients with very low-grade tumors, like grade 1 tumors and some grade 2 tumors, who are young and have had a very good removal, might just elect for observation at this point, meaning we would do a series of MRI scans over months and years to follow for any sign of the tumor coming back. It's very important for anybody diagnosed with a brain cancer to have a long-term follow-up plan. And it would be very unusual after surgery for me to tell a patient that they didn't need to come back anymore, even if they were only coming back for scans. So if you hear that you don't need any more MRIs or anything else done, it would be very good to ask and make sure that that's clearly the point, because most patients will at least get follow-up imaging. Many patients with grade 2 tumors, and almost all patients with grade 3 and grade 4 tumors, even after the best surgical resection, will hear recommendations from their treatment team to consider chemotherapy or radiation therapy, and sometimes the two are given together. It would be very common to set out a treatment plan that would go on for a number of months, and it might be that the patient would get radiation as the first step, maybe with a low dose of chemotherapy given at the same time, then take a brief pause, and then move on to getting regular chemotherapy for a defined period of time, or at that point the period of time may not be known. So you should often expect to hear at this visit about a treatment plan that would involve both radiation and chemotherapy. Obviously, this has to be individualized for each patient's case. The goals of the doctors and nurses treating you for your brain tumor, as they set out the first treatment plan after surgery, are several. The first is to protect the function of your brain and keeping you or your loved one functioning at the highest possible level. Because the brain is involved with the tumor and is such a key organ to who we are and what we think and what we do every day, we have to pay special attention to brain function and the impact of both the tumor and the treatment on brain function in order to maintain very high qualities of life for our patient. The goal of all of this treatment is to find the tumor cells that either can't be removed or can't be seen on MRI, and to treat them. Those that aren't visible on MRI are very difficult to remove surgically. But every tumor cell has a blood supply, and that blood supply can be used to deliver chemotherapy. And every tumor cell of a brain tumor is in the brain somewhere, and radiation can be used to target those. So at this point, chemotherapy and radiation often become the mainstays of treatment. It's very common for patients who've been diagnosed with a brain cancer to undergo radiation therapy as a part of their treatment plan. Let's talk for a couple of minutes about what radiation therapy is, how it works, and what it's like for patients who go through it. The goal of radiation is to find the tumor cells in the brain and to treat them while sparing the surrounding normal brain tissue. Usually this is done by spreading the radiation out over a number of weeks. This allows the brain cells to heal each day, so you might come each day during the week and get a small radiation treatment, and both your normal brain and your tumor would feel that radiation. But the brain has the ability to heal, and so each night the brain can improve, and the next day you come for a little radiation, and everybody feels that, but overnight the brain heals. And over time we hope to create a treatment effect where the tumor is very affected by the radiation, but the brain maintains its normal function. And this is the primary goal of radiation. It can be a very powerful tool in treating brain tumors. Some tumors respond beautifully to radiation, and we call those radiation-sensitive tumors. Other tumors don't respond very well to radiation, and those are obviously called radiation-resistant tumors. It may be difficult to know whether your particular tumor is sensitive or not to radiation without treating it and seeing what the response is. The vast majority of patients with brain cancer will get radiation at some point in their treatment. The radiation involves small doses every day. It's not particularly painful, it's not particularly dramatic, but it does make many patients tired. It does have some potential side effects like any cancer treatment, and you should ask the radiation oncologist, the doctor who specializes in radiation treatment of cancer, to explain to you the particular risks that might come from giving radiation to this area of the brain. It's very common for patients diagnosed with brain cancer to get chemotherapy as part of their treatment. There are many different kinds of chemotherapy that patients get. The simplest ones are pills that may be taken lifelong. The more complicated ones may involve multiple chemotherapies which are given through IVs or infusions and require people to be in the hospital. I'm going to talk a little bit about the most common chemotherapies that are used for brain tumors. Fortunately, the most common drug that's used for treating brain tumors is a drug called temozolomide or Temodar. This is a pill drug. It's often given over a 5-day period, say the first 5 days of the month, and then the patient has the rest of the month where they don't take chemotherapy while the drug is working in their system. While no chemotherapy is without risk or without some side effects, this is a drug that's easier to take than many of the chemotherapies. As I meet patients who are very nervous about starting chemotherapy, I'm comforted to know that I can reassure them that the first drug that we'll frequently use, this Temodar or temozolomide, is very well tolerated, and frequently patients are able to resume work or other normal activities while they're taking the chemotherapy. It usually doesn't make your hair fall out either, which is good for patients who have a tumor on the head and in the brain. Temozolomide is not the only chemotherapy that's used for brain tumors. There are a number of different chemotherapeutic drugs and even non-chemotherapeutic drugs, which we now call biologic agents. These are therapies that target particular weaknesses in the tumor cells, but work in a little different way than the traditional chemotherapy. And there are many of these types of drugs that are used to treat brain tumors as well. One very common one is a drug called Avastin or bevacizumab. And this is a drug that targets blood growth within the tumor. And it's a very common drug for patients with brain tumors to get. It's usually given after the temozolomide is given, but there are studies and treatment paradigms where it's given at the time of the diagnosis of the tumor. This is something you'll want to work out with the neuro-oncologist or medical oncologist who's involved in your care to decide what would be the right order of the drugs to best target your particular tumor. Even after we've used temozolomide and Avastin, this bevacizumab, there are a number of other chemotherapeutic drugs that can be used. So even if one of these first two isn't the best drug to target your tumor, there'll be other options that are available. Many patients are comforted to know that there is a rich network of researchers and doctors around the world working day and night to find new treatments for brain tumors. When these treatments are first available, they're usually done as part of clinical trials. Many patients who have a brain tumor will find themselves treated on a clinical trial. The clinical trial may test existing drugs used in new combinations, or it may test a brand new drug that's not been used for brain tumors before. All clinical trials involve a certain amount of risk and require very careful explanation from the physician or researcher who's running the clinical trial to explain to the individual patient what the benefits and potential risk would be of that. All of the treatments that we give today at one point were tested in clinical trials and were found to have a positive results. Those trials went on to be our standard treatments that we use today. The hope of the future will come from the drugs that are in clinical trials today. The decision about whether or not to join a clinical trial is a very personal one, and each patient and their family make that for themselves. Every patient weighs for themselves the standard treatments that are available versus things that are available in a clinical trial. Remember, everything that we use today as a standard trial was in the past part of a clinical trial that proved to be successful, and that moved over to being a standard treatment. You and your oncologist and your family will decide whether a particular clinical trial offers enough promise and hope for you to choose that over a standard treatment, Or you may move to a clinical trial after you've tried one of the standard treatments and it's not working as well as we would like. There's tremendous promise in the new drugs that are being tested in clinical trials, but there's a certain amount of uncertainty about how effective that drug will be and what the side effects would be. Nothing goes to clinical trial without very careful testing to try to pinpoint any major complications. A particular drug that's very unsafe would never make it to a clinical trial. It's important to weigh clinical trials and standard therapy in order to chart the best course for you or for your loved one. You may be approached at the time of your surgery or biopsy to donate some of the tissue for study, and you may wonder why that's being done. Let me take a moment and explain that. Much of the progress that's been made in fighting cancer in the last 1 and 2 decades has come from studying the tissue that was removed from patients, looking at the genetic alterations, and then designing treatments that are aimed at these weak spots in the tumor. Nowadays, we can take your particular tumor and test the genome, and we may be able to pick particular tumors for you based on what we find in your own tumor type. This is really the start of personalized tumor therapy. I think it's very valuable, whenever possible, to bank and store that tissue so that it can be used not only to benefit you, but also to benefit others who are diagnosed with the same type of tumor. I always encourage, but never require, my patients, if there is extra leftover tissue, to allow us to bank that tumor and, with certain restraint and guideline, use that to find new treatments both for them and for others diagnosed with brain tumors. Let's talk for a moment about the prognosis for patients diagnosed with brain tumors. And once we get through the first round of therapy, of surgery and radiation and chemotherapy, what you can expect to come in the months and years that lay ahead. In general, the diagnosis of brain cancer is one that will need to stay active in your medical care the rest of your life. By that I mean that you'll have a team of doctors or a particular doctor who you identify as your brain tumor doctor who will be following this. They'll be in charge of ordering the appropriate scans, modifying your therapy, counseling you about what the appropriate treatment is. In patients who are doing very well, this may just be a series of MRI scans. In patients whose tumor has progressed or grown, it may mean changing therapies, either to a different form of the same therapy, a new chemotherapy, or going back to radiation or surgery in a follow-up mode. At any point when the tumor starts to grow, we revisit all of the treatment options. The other important thing to be asking your physician is to make sure that they're constantly looking for new treatments that are available. We have things available to treat patients today that weren't routinely used 3 or 5 years ago. We want to make sure that everybody's treatment is based on the most current data and incorporates all of new treatment options. One of the most important members of the treatment team is the patient and their family. I always like my patients to be very well informed about their disease and very involved in the treatment plan. I want to make sure when you leave a visit with me that you understand exactly what the next step is, when the next visit will be, what if any treatment is ongoing. If that's not clear before you leave your doctor's office, I would encourage you to pause and to ask them to explain again exactly what the next few steps will be. More and more physicians are providing doctors with written summaries, either through a patient portal, paper form, or by email, that summarizes the key findings of the visit. And I find that very helpful as a physician in making sure that the key messages are out to my patients. And I know the patients find it very helpful in making sure that they didn't miss anything during the visit. Other key questions you may want to ask may relate to whether you're starting a new treatment, and if you are, what potential side effects are from that. Whether there are other treatment options that you might consider at this point. Many patients like to know whether the treating physician has other patients who've gone through the same thing, and if so, what side effects they've had, what positive benefits they've seen, and at times whether you could talk to them and ask them directly about what their experience has been. Often another patient can be a terrific resource because they're actually going through the chemotherapy or going through the radiation. The doctors order these things and prescribe them or perform them, but we're not the patients and we don't have that same experience. Most important to me at the end of every visit is that it's clear in the patient and the patient's family mind exactly what the treatment plan is, what the next steps are, and what things the patient is responsible for doing. I have a few patients where I fear if they didn't get their appointment slip in the mail, I would never see them again. Those are the hardest patients for me. I prefer my patients where if the mailman drops the slip, they would call me up the next day and say, hey, I was supposed to have an appointment in 2 months and I haven't heard from you. What's happening? Well-informed patient is a key part of our treatment team. Being diagnosed with a brain tumor is a very scary ordeal for patients and their family. Usually this sort of news comes out of nowhere, and at first patients feel very unprepared to deal with making complex medical decisions and other life decisions based on this new news. I would encourage you, to the extent that you can, to get your family and friends involved, to bring them with you to visits. They can serve not only as a source of support, but can also listen, ask good questions, and later help you recall exactly what was discussed in your visit. I'd also encourage you to try to find other patients who've gone through things that you're currently going through or will face in the future. Organizations like the Guideposts of Strength can provide patient mentors and also mentors for your family who can provide significant insight and reassurance to you as you start down this journey. Brain cancer is a difficult disease to treat, but there are many, many promising therapies, and I personally have many patients who have fought the battle with brain cancer and gone on to live wonderful, full lives. Good luck to you, and thank you for your time.